Again, a very important topic in diabetes, and the speaker is Dr. Ramadoss from JIPMER, Puducherry.
Good afternoon, everyone. At the outset, I thank the organizers of DiveCon 2023 for giving this wonderful opportunity. My topic is about stress hyperglycemia. We all know that there are two types of stress. One is psychological stress, another one is physical illness-related stress. My talk is about physical illness-related stress, not about psychological stress. Let me start with a case scenario. We have a 50-year-old man who is not a known diabetic and he is admitted in the hospital for acute coronary syndrome. His glycemic status shows RBS is 210 milligram per deciliter. His HbA1c level is 7. That is in the diabetic range. So in a non-diabetic man who is having hyperglycemia and the HbA1c is in the diabetic range, so we will label him as newly detected diabetes mellitus. In case his RBS is high, 210 milligram per deciliter, but his HbA1c is in the normal range, 5.5 or less than 6.5, then we will call this condition as stress hyperglycemia. Here the stressful condition is acute coronary syndrome, because of which the glucose level has gone high. That's why this condition is called as stress hyperglycemia. So these are the contents of my talk. We will have an introduction, definition of stress hyperglycemia, pathophysiology of the condition, what's the clinical importance and how to manage it. So coming to the introduction, stress hyperglycemia is nothing but a surge in blood glucose level during acute ailments. Initially, it was thought that it's an evolutionarily preserved adaptive response which increases the chance of survival. Later, the researchers found that it's an index of level of stress in critical illness. The incidence of stress hyperglycemia ranges from 9 to 50% based on the settings and the disease on which this condition was studied. Further, the researchers found that the patients having stress hyperglycemia carrying poor prognosis comparing to the diabetic hyperglycemia. Coming to the definition, there is no universally accepted definition for stress hyperglycemia. Whatever I have found is, in ADA guidelines, there is a statement that if an in-hospital blood glucose levels are recorded more than 140 milligram per deciliter, then we have to go for HbA1c testing. Based on this statement, this definition is derived and used in many studies. That is, in-hospital blood glucose level more than 140 milligram per deciliter with HbA1c of in the non-diabetic range. That is called stress hyperglycemia. But in an Indian guidelines given by RSSDA have defined this condition when the FBS is more than 126 or random blood glucose level more than 200 and the HbA1c level is normal during the hospitalization, but it reverts, this hyperglycemia reverts to normal after hospital discharge. It will be considered as stress hyperglycemia. So coming to the pathophysiology, we all know that during the acute illness, there will be an elevation of cytokine levels. These include TNF, interleukin 1, interleukin 6, etc. These cytokines will in turn increases the insulin resistance, which causes this stress hyperglycemia. Not only the cytokines, but also there will be a surge in the counter-regulatory hormones like cortisol, glucagon, catecholamine and growth hormones. These hormones will reduces the insulin secretion, increases the gluconeogenesis happening in the liver, and it also increases the insulin resistance. So these are the mechanism contributing for the stress hyperglycemia. So here is the protocol, flowchart. We can see that how this stress hyperglycemia causing deleterious effect to the patient. So because of stress hyperglycemia, there will be an immune dysfunction and excessive production of reactive oxygen species. Because of immune dysfunction, patient will be more prone to get infection. Because of elevated reactive oxygen species, further inflammatory mediators will be released, and these changes will cause the cellular injury, inflammation, tissue damage, and infarction, acidosis, etc. These changes will further lead to the prolonged hospital stay, disability, and even death to the patient. So coming to the clinical importance, why should we know about this condition? To emphasize the clinical importance, I want to show the result of few studies done on this condition, stress hyperglycemia. So here is a study done in Korea on 12,000 odd acute MI patients. In this population, 1/3 were diabetics and 2/3 were non-diabetics. Their admission blood glucose level were measured. The outcome monitored in this study was in-hospital mortality. In the graph, we can see that in the y-axis, in-hospital mortality is plotted. In In the x-axis, there are two groups. One is admission glucose more than 200, another is admission glucose less than 200. Among the admission glucose more than 200 group, we can clearly see that the patients who are non-diabetic having significantly high in-hospital mortality comparing to the diabetic patients. Coming to the critical illness, this study is was done in Australia on 2,300 hospitalized patients. Admission blood glucose was measured and the HbA1c level was also done. Based on the HbA1c level, the study population was divided into diabetic and non-diabetic. The outcome measured here was critical illness, that is, that includes ICU admission and mortality. In the graph, we can see that in the x-axis there is admission blood glucose level, in the y-axis critical illness is plotted. So comparing to the diabetic group, non-diabetic people who are having high admission blood glucose level having significantly high critical illness percentage. So this is the result of a study done on 265 severe sepsis patients in Greece. It included 18% of stress hyperglycemics, 25% of diabetics, and 57% of normoglycemics. Here also in-hospital mortality was measured. So here also we can see that comparing to the normoglycemic and diabetic people, stress hyperglycemics are having high in-hospital mortality. So the risk is not only limited during hospital stay, but also continues beyond the hospitalization. Here is the result of a study done on 591 non-diabetic hospitalized patients. They were two-thirds of normoglycemics and one-third were having stress hyperglycemia. These people were followed up for 5 years whether they are developing diabetes or not in future. So after 5-year follow-up, 3.5% of normoglycemics and 17% of stress hyperglycemics developed diabetes mellitus. So the almost 5 to 6 times high risk of developing diabetes in future if the patients are having stress hyperglycemia during hospitalization. So coming to the investigation, to diagnose this stress hyperglycemia, we need RBS and HbA1c level. Some studies advised FBS also to confirm the diagnosis. So if the blood glucose is more than 140 and HbA1c is in non-diabetic range, we can call this condition as stress hyperglycemia. But there is a catch here. We can see this three scenario where all these three patients are having similar RBS level 210, but their HbA1c level varies. But we can note that all the HbA1c level are less than 6.5. So all of them are qualified to consider as stress hyperglycemics. But is there any measure available to quantify the stress hyperglycemia? Yes, it's available. It's called stress hyperglycemia ratio. So we will see how to calculate that. Stress hyperglycemia ratio is calculated with the formula of admission blood glucose or random blood glucose divided by estimated average glucose. This estimated average glucose is derived from the HbA1c levels by using the formula which I have mentioned here. So by applying this formula in this example, we can, in the yellow letters showing the corresponding estimated average glucose for each HbA1c levels. And here we have calculated the stress hyperglycemia ratio. So we can see that patient 1 having higher ratio comparing to patient 2 and 3. So this is the formula used for quantifying stress hyperglycemia. Coming to the treatment, there is no separate guidelines for treatment of stress hyperglycemia. Whatever the guidelines available for managing in-hospital hyperglycemia can be used for treating this condition. So if the patient is non-critically ill but having stress hyperglycemia, they can be managed in a non-ICU setup. They can be managed with subcutaneous insulin. If the patient is critically ill, wherever they are managed, either in ICU or non-ICU, IV insulin infusion should be considered. So there are so many regimens for giving IV insulin therapy. This is one of those regimens. You can calculate the initial dose based on this table. Further, you can titrate the insulin doses based on the glucose monitoring in future. And coming to the monitoring for critically ill patient, if they are having stress hyperglycemia, we should monitor the sugar levels every 1 to 2 hours. For stable patient, it should be monitored every 4 to 6 hours. The target blood sugar should be, for critically ill patients, the sugar should be maintained between 140 to 180 milligram per deciliter. For stable patient, fasting should be less than 140 and postprandial should be less than 180. And other things should be considered while treating this condition are the primary illness caused the acute stress should be addressed, and we should be careful when we are giving the IV fluids and drugs causing hyperglycemia while treating this patient. Blood glucose level should be stabilized before the discharge, and patient should be advised for lifestyle modification and at least annual screening for diabetes mellitus, because this condition carries risk of developing diabetes mellitus in future. My take-home message, sir: stress hyperglycemia is defined as admission blood glucose or random blood glucose more than 140 with HbA1c level in a non-diabetic range, and the quantity of stress hyperglycemia can be measured by using the formula admission blood glucose divided by estimated and average glucose. Stress hyperglycemics are carrying poor prognosis comparing to diabetic and normoglycemic individuals. The management is similar to the in-hospital hyperglycemia, and the patient should be monitored for future development of diabetes mellitus. So let me conclude my talk with this verse from the Tamil literature Tirukkural. Utran alavum, pini alavum, kalamum katran karidi cheyal. A doctor should have a measure of the patient, the disease and its stage, and then treat it. Thank you.
Thank you, Dr. Ramadoss, for talking about a subject, I think, which is, again, a very understudied topic, stress hyperglycemia. I think the takeaway for me and for, I believe, for all of us is to pay more attention to stress hyperglycemia in our inpatients and not just pay attention to only the diabetic patients. I think the data is very alarming to know that any patient who has stress hyperglycemia can have a 17% risk of developing diabetes over the years as compared to a normoglycemic patient. And the studies that you showed, the Australian, the Greek study, and the Korean studies, all are very significant in terms of the impact that stress hyperglycemia may have on the outcome of these patients, not just the mortality, but also the morbidity of these patients. So I think, again, the take-home is that we should pay more attention to stress hyperglycemia. We should monitor these patients as vigorously as possible, given the constraints, and then treat these patients in our hospital settings. So I believe if there are questions from the chairs or from the audience, we can invite one or two questions. And thank you for completing your talk well within the time.
Thank you, sir.
I have just one question. In the same study in which there was 17 to 18%, incidence of development of DM in 5-year follow-up, were there any risk factors that determine the development of diabetes in those cases, not in other 80% of cases?
Okay. Actually, mainly they have considered their baseline admission glucose levels only, sir. So from that only. Apart from that, they have divided other risk factors like hypertension and obesity that were also there in the
Normal risk factors.
Sir?
Normal risk factors or no specific risk factor for
No, nothing was specified like that.
So as far as the risk profiling of these patients is concerned, as far as I understand, there is no risk profiling of any patient who can be, let's say, prone for stress hyperglycemia in such cases. The critically ill patients, the trauma patients, the ICU patients are, of course, more at risk of developing a stress hyperglycemia, and that's why the acute coronary syndrome patients need to be vigorously monitored for the
Mainly
control of
because
blood
of the
sugar.
cytokine surge and the counter-regulatory hormones.
That's right. The IL-6, IL-1. So, Dr.
You
Rajiv.
answered that
Sir.
question. Is it possible to pre-diagnose or to find any risk factors? Who are the people who are more prone to develop this?
Sir, mainly the definition used here was less than 6.5% of HbA1c. So the pre-diabetics must be more prone to develop the stress hyperglycemia as well as the future diabetes comparing to the patients who are having HbA1c level in the normal range, that is less than 5.7.
What's your...
Yes, sir. In COVID also there is a study done on this.
So I think COVID pandemic, yes, I was just coming to that question only. COVID pandemic, probably because a lot of patients had got steroids, right? It was steroid-induced hyperglycemia. But patient didn't get the steroids. Still they developed hyperglycemia because of the stress factor as well as the virus itself can cause some pancreatic insufficiency causing, and
That's right.
that causes those patients to develop diabetes in future. That has to be seen.
So what's your recommendation? I believe this is the final question. What's your recommendation? Any patient who gets admitted as an inpatient in a hospital should have a HbA1c and an average blood glucose to see the stress hypoglycemia ratio to risk stratify, to answer Dr. Rajiv Gupta's this thing?
Definitely, if the RBS is recorded more than 140, HbA1c testing should be done. Next thing is, if it is stress hyperglycemia, then that patient should be followed up at least every year, and they should be advised for lifestyle modification to prevent the risk of developing diabetes in future.
All right, thank you very much, Dr. Ramadoss, and thank you to the chairs. I think we'll move on to the next session.